Thank you so much for the opportunity to present this PAD invasive therapy slide set on behalf of myself, Andrew Klein. I'm here from Piedmont Heart Institute in Atlanta, and Dr. Dimitri Feldman at Cornell Medical College in New York. Today we're going to talk a little bit about peripheral arterial disease, and we'll review the guidelines for endovascular therapy for the main three vascular beds: aortoiliac, femoropopliteal, and infrapopliteal. Give you a brief overview of device-specific data, as well as go over the SCAI appropriate use criteria and device-specific guidelines for endovascular therapy of these vascular beds. What we do know is that there's been an increasing use of endovascular interventions across the screen over the last 2 decades. If you look at the national inpatient sample study from years about 2001 to 2007, we've seen a 78% increase in endovascular interventions. While at the same time, we've seen a drop in open lower extremity bypasses, given the associated decrease in morbidity and mortality with endovascular intervention versus open. And with that, we've seen a decreasing number of major plus minor amputations across the field, highlighting that, in fact, endovascular intervention is having a major outcome on patient quality, but also on their morbidity. If you look at the symptomatic patient, really, when I discuss this with patients in the clinic, really we're talking about 3 main vascular beds here: aortoiliac, femoropopliteal, and infrapopliteal. And when you look at aortoiliac, I think endovascular approach is supported as the first-line approach to go for patients who have symptoms from obstructive atherosclerotic disease. Endo first, unless there's a failure of endovascular therapy or AAA is being considered. In that case, you would send the patient for both AAA and endo repair at the same time, or open repair if that was being used for the repair of the AAA. When it comes to the femoropopliteal segment, this is a more challenging segment given the complex forces that occur there, failures of prior therapy, and really depends upon the type of disease that's really present. Are we looking at focal, or are we looking at diffuse? Is it 10 millimeter lesion or 250 millimeters of lesion? Is it a stenosis, or is it a complete complex chronic total occlusion? Task class does play into this, but what we now know is that TASC C and D lesions can be revascularized on a standard very easily using standard techniques. It also depends upon who the patient is, patient risk factors and comorbidities. Are they a patient with advanced heart failure and multiple comorbidities that are not going to do well with an open surgery, or is it someone who's going to do well with an open surgery? Also, when you're looking at, is it something that should be treated just with medical therapy or with exercise therapy? Again, this all weighs into what is the patient look like and their comorbidities. And then additionally, if you're looking at claudicants versus CLI, claudication is very akin to stable angina in the coronary realm. These are patients that are going to do well with medical therapy, going to do well with exercise therapy, but obviously we've seen an improvement with some studies with endovascular therapy plus exercise therapy being better than just exercise alone. And that's in contrast to patients who have critical limb ischemia. These are the sickest of the sick patients, and really your goal there is to establish inline direct flow to the wound to be able to heal the wound or relieve the patient's rest pain. The goals here are very, very different. And then also we're looking at long-term patency. Again, CLI patients are much sicker, they're older, their long-term mortality is much, much higher than a claudicant who may have 20, 30 years left of life. Here you want to look at long-term patency. How often are you going to be back here repeating this if you're going to do an endovascular procedure? And obviously all in the setting of renal function. Again, looking at the risk of endo versus open versus medical versus exercise. And the approach is really changing with drug-coated balloons. Now we're seeing a much decreased target lesion revascularization using DCBs, and this will continue to evolve. That's for the femoropopliteal segment. If you look at the infrapopliteal segment, really it's medical therapy for most, unless you're talking about critical limb ischemia. And in that case, we really want to open up direct line flow to, again, whatever that wound is, or if the patient has rest pain. Here, drug-eluting stents are really a consideration. We've had 5 randomized controlled trials looking at that, showing a benefit of infrapopliteal drug-eluting stents for short lesions. However, as all of us know, very rarely do you just see focal stenotic lesions in these patients. Usually it's diffuse. And really, in endovascular therapy for the infrapopliteal vasculature is a category 2B recommendation unless CLI is present. So let's discuss a little bit here about exercise and peripheral arterial disease. We have 2 major trials showing the benefit of exercise. namely CLEVER, which was an RCT trial of aortoiliac, really looking at EVT or exercise endovascular versus optimal medical therapy versus supervised exercise therapy. And in 18 months, what we've noticed is that patients walk better for both if they get endo therapy or if they get supervised exercise therapy, but not optimal medical therapy. And really the quality of life was better for patients who got endo compared to with both supervised exercise therapy and optimal medical therapy. And so what the slide here on the right is showing very clearly that patients do better with either endo or with exercise. And for those patients who went on for both, they seem to be doing the best. ERASE is a very common, this is the next step to CLEVER, which was looking at both endovascular therapy and supervised exercise therapy versus exercise alone. And this was an RCT including both aortoiliac and femoral popliteal claudicants. And what we see here is that if you do both, you revascularize the target vessels, aortoiliac or femoral popliteal, and you get them to exercise, they have the greatest improvement in walking distance and health-related quality of life. And that's better than supervised exercise therapy alone. So the take home really from these trials to me is that, and I think to many of us, is that it's good to do both. You need patients both to get revascularization, to be able to improve their walking abilities, but also to be able to walk in addition. As I advise patients, you can't just do one thing, you have to do both. And I think this goes to the underlying pathophysiology, which is you can restore blood flow to the muscles. However, there's clearly been shown in more basic studies some changes in the architecture and the gene regulations at these muscle level, and what you need to do is both stimulate the exercise stimulates these genes to improve muscle strength, and you have to do that plus the revascularization. So you can't just do endovascular therapy alone, you need to do it in combination with supervised exercise therapy, all in the presence and the foundation of goal-directed medical therapy, understanding that patients, again, generally don't die from the peripheral arterial disease, they die from cardiovascular and cerebrovascular events. So all this has to be done in the setting of excellent medical therapy, namely aspirin, statin, blood pressure control, diabetes control, smoking cessation. So let's talk a little bit about femoral popliteal disease for an exercise therapy, specifically for this disease segment. We have here from the Ironic trial data looking at RCT of, again, both aortoiliac and femoral popliteal. They got revascularization that was about 79 patients plus optimal medical therapy versus optimal medical therapy alone. So this is very similar, but instead of using exercise here, as in the previous trial, here we're using optimal medical therapy alone. And really what we show here is that the Ironic trial demonstrates that if you do endovascular therapy plus optimal medical therapy with respect to onset of claudication and quality of life, clearly endo plus medical therapy does better than just medical therapy alone. And intermittent claudication distance improves significantly in the invasive arm, almost 124 meters versus the non-invasive arm. So really, you can't just do medical therapy for these patients if you want to optimize their outcome in terms of quality of life and their onset of claudication. And really, the Ironic trial is showing us that, again, on that foundation of optimal medical therapy, that the superiority of endovascular therapy plus OMT is better than OMT alone. So with that, let's look a little bit at the symptomatic patient guidelines for endovascular therapy. In 2005, it was really a class 1 indication, mainly for aortoiliac, again, where the risk-benefit ratio favors doing endovascular therapy. And to 2016, that continues with a class 1 level evidence A, endovascular procedures are effective as revascularization options for patients with lifestyle-limiting claudication in hemodynamically significant aortoiliac occlusive disease. Again, kind of promoting what we just spoke about, which is for aortoiliac, really endo first is the approach to go. Previously, we had looked at the task guidelines as some guidance for us to really show us which way to go, and I think what we're seeing is that this is a document that is now over a decade old, and thanks to advances in technology, we can now see that we can even approach the most difficult or task D lesions endovascularly. So previously, a decade plus ago, we would say surgery only for task C and D lesions, and today we're really talking about an endovascular therapy approach for most lesions. Specifically at the in the aortoiliac and also for the popliteal, it is not uncommon to revascularize patients that have complex occlusions in the distal external iliac extending to the common or any combination of these C&D lesions using endovascular therapy with dissection reentry and reentry tools. Same thing here in the femoral popliteal segments. It is not uncommon for operators to be able to cross lesions of TASC-D significance with relative ease, depending upon their experience. Again, this is something that needs to be done in experienced hands. But TASC-C&D lesions both in the aortoiliac and the femoral popliteal can be revascularized safely endovascularly. So currently, the indications for aortoiliac revascularization with and without symptoms are as follows. If you have symptoms, patients have claudication. Again, understanding that 10 to 30% of patients may have atypical symptoms. Your goal is to revascularize to relieve claudication, or for those patients who have critical limb ischemia, promote wound healing and or improve functional status and quality of life. Again, underscoring that patients with these disease subsets die from cardiovascular complications, we tell our patients always to walk and to improve your outcomes from a cardiovascular side. Obviously, if they can't walk, they don't want to do it. So we really want to improve their walking ability to improve both how they're doing in terms of their quality of life, but also decrease their CV morbidity and mortality. There are indications for revascularizing the aortoiliac without symptoms. Mainly those are where you have to place a large bore arterial access, either a balloon pump or some other catheter-based ventricular assist device, including Impella or ECMO, for structural or valvular interventions as well, including TAVR, or for EBAR procedures. So if we have to go through there and we're going to destroy the vessel on the way or dissect the vessel, that's another indication, or induce acute limb ischemia, as has been shown and published, using balloon pumps in patients that have severe stenosis, that it's important that you revascularize these vessels prior to placement of those devices. What's the data regarding complex aortoiliac disease, specifically TASC-D? Well, endotherapy, as I mentioned, is possible, it's safe, and has a durable short and long-term patency. We have some data from Japan looking at over 2,000 patients, 400 of which had TASC-D lesions. And if you look at the data, at least in this 5-year primary patency, is that it's around 78%, which is outstanding, with no difference here if you're looking at TASC-A through C and more complex TASC-D. Major adverse cardiovascular and limb events occurred about 1/3 of the time. Again, no difference if it was TASC-A through C versus TASC-D. However, TASC-D lesions are a little bit more challenging, and so you do have a lower procedural success rate, 91% versus 99% TASC-D. That's underscoring how challenging this patient population can be. You also have a higher complication rate, almost 11% in the TASC-D lesions versus 5.2% in the less complex TASC-A through C. This underscores the importance to have an open and frank discussion with the patients regarding the risks and benefits of endovascular revascularization, also an honest assessment of the skill set of the operator or operators performing these procedures. These are very complicated procedures that need to be done either in tandems and teams with high operator experience or with single operators with excellent experience in this arena. And to be prepared for any complications that occur as aortoiliac rupture or vessel rupture, as these can be fatal in this patient population, especially with given the size of these vessels. So what about stent selection? Speaking of which complications, if you look at the COBAS trial, which is a randomized controlled trial of 168 patients, TASC-B through D, looking at covered stents versus bare metal stents, really this showed that covered stents had lower restenosis rates versus bare metal. Not surprising, because covered stents can't get endothelialized for in-stent restenosis. However, when you looked at it a little more closely, we show a lower restenosis rates in the TASC-C and D lesions versus bare metal stenting. Now that may be biased, because if you're putting up a covered stent, you feel more comfortable inflating that stent and leaving a bigger diameter. You feel more confident that if the vessel ruptures, you already have it covered. So this may be biased in that respect. However, clearly there's lower restenosis rates using the covered stents versus the non-covered stents. If you look at 5-year patency rates, it improved at 18 all the way up to 60 months. And more recently, if you talk about which stent to use, self-expanding versus balloon expandable, there was the ICE trial, which looked at 660 common and external iliac lesions randomized to self-expanding or balloon expandable. I was always taught that self-expanding stents are better with vessels where there's size mismatch or where there's flexibility or an issue with step down between the vessel size or tortuosity, and balloon expandable being, of course, more accurate. You could place it more accurately because you're going to inflate a balloon. However, if you look at this data, it was very interesting. If you look at 12 months, the restenosis rates were lower with self-expanding stents, 6.1% after self-expanding versus 14.9% after balloon expandable. And the freedom from TLR favored self-expanding stents at 97% versus 94%. Now, that's pretty good freedom from TLR at one year. Again, almost 94% patent, even with the balloon expandable. There are some issues with this trial, and I recommend reading the editorial, which was actually written by Dr. Feldman and myself regarding this trial of Don't Fall Through the Ice, because there are some issues with the trial itself, and I think there are options in this arena as per which stents are better. But clearly, this is the first data to suggest that, in fact, self-expanding stents might be better in external and common iliac arterial lesions. So if you look at the appropriate use criteria, looking at aortoiliac intervention, a provisional primary stenting is appropriate when vascular access is required. Again, that's for balloon pump or for TAVR procedures. Most of the time you can inflate a balloon, advance your equipment, do what you need to do up at the heart, and then the balloon result is fine. It is appropriate for greater than 50% aortoiliac stenosis or gradients of greater than 10, or in claudicants who fail medical and exercise therapy. And it is appropriate for all patients who have critical limb ischemia, Rutherford 4 through 6. Really, these are the biggest vessels in the body. As we know, flow is proportional to the radius squared. Obviously, going out of a vessel with a diameter of 8 and a radius of 4, that's going to give you 16 times more flow. So really, revascularizing these vessels is critical, can get these patients out of critical limb ischemia relatively quickly, even before you go and address the smaller vessels. You look at the appropriate use for a variety of devices, which devices are appropriate or may be appropriate across the board here. If you look at for covered stents or for diffuse disease or for CTOs or even for focal, those are all considered appropriate. You can also use bare metal stents for focal, diffuse, or CTOs. A little bit more and then may be appropriate for just PTA alone versus drug-coated balloon. There is a class 3 recommendation for atherectomy up here. In fact, it may even be lower than a class 3. Remember, doing atherectomy in the aortoiliac is off-label. It's also can be challenging because if you're going to use orbital atherectomy, you're going to send rather large particulate matter downstream, and directional atherectomy is off-label and not recommended in the aortoiliac area. Drug-coated balloons and drug-coated stents are other options. However, at this time, the drug-eluting stents are not available in certain sizes that can cover these lesions. But really, we're going to see this more evolve over the next coming years as our technology also evolves. What about endovascular therapy in the common femoral artery? Well, really, we're dealing with just one trial, but a lot of registry data. It really supports an endovascular therapy approach. This is a much different than where we were 10 years ago. If you look at the 5-year follow-up data, using endo approach really had a 79% freedom from TLR. If you look at the TECO trial or the TECO trial, 117 patients with RCT got randomized between surgery versus endovascular therapy for isolated CFA disease. Primary outcome, again, was morbidity and mortality within 30 days. Obviously, morbidity and mortality is going to favor the EVT arm here versus an open approach. 26% in the common femoral endarterectomy hit that outcome versus 12.5% in the endo arm. The mean duration of hospitalization was obviously lower for endovascular therapy. And more importantly, if you look at the long-term outcomes, at 24 months, there was no difference in sustained clinical improvement, primary patency, target lesion, and extremity revascularization rates. So really showing, again, a relatively small subset, but if you look at the long-term patency here, all the way up to, or what we'd say probably midterm at 2 years, really no difference here between stenting and surgery. What about the retrospective study looking at 47 patients published here just recently in February 2018? This looked at directional atherectomy versus DCB versus DCB alone. This showed no difference. There's been a lot of issues here in terms of what is the optimal therapy. Should we be performing atherectomy to debulk and then treat with a drug-coated balloon, or do you just treat with the drug-coated balloon alone? Here, there's no difference in this relatively small study recently published using DART or directional atherectomy plus anti-restenotic therapy versus DCB alone. This needs to be more borne out in a randomized controlled trial, and I believe that is currently being entertained. So femoral popliteal, shifting gear from aortoiliac into femoral popliteal. If you look at the TASC guidelines and ACC/AHA updates, again, TASC 2015 updated, again, updated from 2007, really recommends endovascular approach here for the femoral popliteal for experienced operators and teams. It's important here to have experienced operators and teams at the helm. 2016 ACC/AHA guidelines and PD provide a Class 2A recommendation. That's gone up from 2B in the past for endovascular therapy of the femoral popliteal disease. Again, the conclusion as recommended by the 2016 ACC/AHA guidelines is the choice of endovascular therapy as a revascularization for claudicants with the FP disease really need to involve a complex discussion here. You need to have a sit-down discussion with the patient regarding outcomes, addressing the likelihood of restenosis, repeat intervention, particularly for lesions with poor likelihood of long-term durability. I think patients often are mistaken. They feel like one event, one procedure may quote-unquote cure them of the disease, but really this is a lifetime disease, and it's important to understand that restenosis rates, even in 2018, still are higher than we'd like them to be, and patients have a tendency to come back for repeat procedures, both peripheral and coronary. What about drug-coated balloons? We have a lot of data now really advocating for drug-coated balloons to be a first-line therapy, and we're going to show some of that. First of all, the IMPACT SFA trial looking at IMPACT paclitaxel drug-eluting balloon, the Admiral balloon versus uncoated balloon with a decent lesion rate of almost 9 centimeters and a total occlusion rate of almost 26% in the DCP arm and 20% in the PTA arm. We show primary patency at 82% versus 52% at 12 months using drug-coated balloons. A much lower rate of clinically driven TLR, only 2.4% at DCB arm versus 20% in the PTA arm. Again, that's what matters. I think when we talk to patients is clinically driven TLR, one of these patients is going to need to come back for a repeat procedure. And if you're seeing a TLR rate of only 2.4% in 1 year, that's pretty impressive. These benefits have persisted out to 24 months, and even more recently published this year was the 3-year data looking at primary patency, again, favoring DCB over uncoated balloon. It did drop. They're showing that over time the drug does dissipate. The benefit of the drug dissipate, but it is still almost 70% at 3 years versus 45% in the uncoated balloon. So midterm results still showing a benefit here of a drug-coated balloon using the Admiral IMPACT paclitaxel drug-eluting balloon versus uncoated PTA alone. Here's the data looking at the 36-month outcome. You'll see a true benefit here throughout the first year. And then over time, this drug-coated benefit may dissipate, and it does actually here, but still maintaining high at 70% over PTA alone. If you look at time from index procedure, again, primary patency, if you look at freedom from CD TLR at 36 months, and again, what the patient really cares about, which is how many times do I need to come back from the lab, not just patency assessed by duplex ultrasound, but from clinically driven TLR, 84% at 36 months. So pretty decent midterm outcomes. We'll see where it is at 5 years for long-term outcomes, but looking much more beneficial than it was in the past with uncoated balloon alone at 70.4%. There are 3 clinically available drug-coated balloons. The second large trial released after IMPACT SFA was the Lutonix balloon in the Levant 2 trial. This is a lower dose or 2 microgram dose of paclitaxel made by the company Bard and the Lutonix balloon looking at improved patency. And here, if you look at PTA versus the DCB alone, we're seeing a 65% rate versus 52% at 1 year. Freedom from primary safety events is about 84% versus 80% with uncoated balloon. Pretty good. However, this is a different balloon. There is a different excipient being used here. And what you're seeing is no real difference here of relatively flat line, and then a decrease or a separation of the curves here at 6 months for standard balloon angioplasty versus drug-coated balloon. And then the signal that was most disturbing here about this, published at the 12-month, was a severe drop here at about 11 months down to 13 months, and that bore out with a no real difference at the 2-year mark. That data is not published at 2-year mark, was presented at the Society of Vascular Surgery 2015 in June of 2015, showing no difference at 24 months, but at 12 months there still maintained a difference. The third balloon available is the Stellarex, made by Philips or Spectranetics. and they published their data under the Illuminate trials, both 1 and 2. This is the pivotal trial looking at 300 patients, Rutherford 2 through 4, looking at the DCB again versus PTA alone. Look at the rates here at 1 year, 82% freedom from loss of patency or patency at essentially 1 year versus 70.9%. Freedom from device or procedure-related deaths through 30 days was clearly no issues with the drug itself, no issues with safety. And the primary effectiveness data showed primary patency, again, at 12 months of almost 73% using DCB versus 57% for the PTA alone, when that was significant. The Illuminate trial is also just released, and it's in press. Their 24-month data also should be showing a difference as well. What about drug-eluting stents? Zilver PTX is the only available, commercially available drug-eluting stent available on the market at this time. We have 5-year data from this, looking at a 2-stage randomization. This was the big Zilver PTX trial. Initial randomization to DES or PTA alone. Patients who initially randomized to the PTA and experienced fluid-limiting dissections or recoil, then went on to stenting, and were secondarily randomized to provisional stenting or with bare metal versus DS. So it's kind of a 2-stage study. The remaining 118 patients not randomized to DS were in the standard care group. And at 5 years, what it shows is that Zilver PTX actually does still show a clinical benefit compared to PTA alone for freedom from persistent or worsening evidence of ischemia. Again, look at DS across the board here, all the way out to 5 years, and this is the only long-term data that we have in this arena. Again, 5-year data being long-term. We're showing primary patency rates up here of almost 70% versus standard care or PTA alone. And so really drug-eluting stents are another option that are out there. The uptake has not been as great, probably due to cost. However, this is clearly an effective strategy for patients. There's also been a push to not leave a metallic scaffold behind. And I think there's this fear of leaving a metallic scaffold behind, which maybe has also decreased the uptake of this product. What about atherectomy? Well, atherectomy comes in a variety of forms, both excisional versus ablative. There's several options out there, but I think it's very important for operators to understand that there's no comparative efficacy data. There's actually no randomized controlled trials using these devices at all. It's all registry-based. And the key thing about atherectomy is that the removal of plaque does involve some risk of distal embolization with these devices. Specifically recommended, or at least generally practiced, is for directional atherectomy to have some embolic protection device placed as well, because distal embolization definitely does occur. There's very limited data to date using atherectomy plus DCB. I showed you the data earlier regarding the common femoral vascular bed, and no data showing benefit of atherectomy plus DCB versus DCB alone. And the big issue here is the cost. These devices can range anywhere from $2,000 to $5,000, increasing the cost of the procedure and healthcare delivery. And so if you look at the SCAI consensus guidelines for device selection, a paper published by Dr. Dimitri Feldman just recently in CCI in 2018, if we were looking at class 1 data or strong evidence versus 2A versus 2B versus 3, we divided into both no benefit or harm, and then the level of evidence there is on your right, A being high quality evidence from RCTs, all the way down to C, which is really just expert opinion. Let's look at kind of where an expert consensus document or a group of individuals publish and what they thought about. And if you look at PTA alone, let's go right to the green for common femoral all the way down through all the SFA popliteal. If you look at as definitive therapy, now this is not adjunctive, but as the final therapy that you would do, DES has been gotten class 1 because the data I just showed you. DCB is also getting class 1 across the board here because of the data just recently presented to you. If you look at the data for in-center restenosis for focal lesions, again, drug-coated balloons, as well as intermediate lesions, chronic total occlusions, again, drug-coated balloons and DS are being recommended. I think the important thing about this is as a definitive therapy, again, final therapy being used, atherectomy is getting a class 3 no benefit across the board, all red to the right-hand side of this screen here. And same thing if you look at just for definitive therapy for PTA alone, versus specialty balloons, a lot of class 3 being present there, and I think it's important to take note of it as your definitive therapy. I think a lot of operators also look at adjunctive therapy, and that's different than definitive. So this is where you treat the lesion first using this and then go on to a definitive. So I think many of us use DCB as the definitive therapy after we've done something else. Now, maybe if, again, looking at the data here, when is, for instance, atherectomy being recommended? 2A recommendations for orbital or rotational. Again, in lesions that are non-dilatable, focal lesions, intermediate or diffuse. Again, that's for orbital or excisional or aspiration. Class 3 for directional. Again, no RCT data supporting this. Not a lot of green here. As you can see, not a single class 1 recommendation here is adjunctive therapy. A couple 2As here looking at specialty balloons for lesions that are non-dilatable, be it the chocolate balloon or the cutting balloons. For ISR, again, laser atherectomy, getting a 2A recommendation across the board here. And the reason for this is data, actually RCT data from the Excite ISR data, showing a benefit of laser atherectomy in this subgroup. Laser is the only FDA-approved device for in-stent restenosis. Clearly, we have a dearth of trials and a dearth of research in this area to treat in-stent restenosis, a wide open area, and we hope to see more data here in the coming years. Of note, it is a class 3 harm recommendation to use any orbital or rotational atherectomy device for in-stent restenosis. All these devices do is basically send a bunch of rubbery debris downstream. This is absolutely not recommended at all. Again, if you look at the consensus guidelines for device selection, here's a sample algorithm for treating focal SFA disease, and that's in contrast to diffuse disease. One can walk through here and figure out exactly which way to do. Again, if you're looking to follow class 1 recommendations, you would go down with pre-dilatation with a class regular balloon, and then flow limiting dissections. If they had flow limiting dissection or greater than 50% residual stenosis, you would consider going on to DCB. If the balloon is non-dilatable, you could go through specialty balloons if a standard balloon doesn't work, again, for lesions that are non-dilatable. So one can walk through here for each individual step that you want to go through to get down to stenting. Again, DS and DCB getting class 1 recommendations. That's different from diffuse disease, which is more common in these lesions. Again, DCB and DS. Also, there's some level 2 evidence looking at covered stents for these from the Viabon and the ViaStar trial. Again, a 2A recommendation for diffuse disease. That may be another available option for operators to choose from. So here's a very larger table looking at femoral popliteal interventional scenarios, appropriate use criteria, looking at a variety of options that are be appropriate or may be appropriate. Again, PTA for focal lesions, I think we have the data for that. That's been recommended as far back as TASC document in 2007. DCB, bare metal stent, or DS for more challenging lesions, and atherectomy only for undilatable lesions. Again, I think you can find your patient, see where they are. Again, you shouldn't be operating or doing procedure on some patients that have 0 symptoms or very mild. For those patients that have moderate to severe symptoms, again, going across and figuring out what would be the optimal or appropriate therapy for this. PTA alone, bare metal stenting, DS, DCB, get your green. Also for lesions that are more moderate or diffuse, again, working our way towards drug-coated balloon. That is this column here, or drug-eluting stent. Very similar to what you see in the device selection document from Dr. Feldman. So what about infrapopliteal revascularization? Generally, again, as we mentioned earlier, this is limited to critical limb ischemia patients only. Really, you're looking at small vessels here. These are very, very small vessels equivalent to the coronary, but they're much, much longer. They have often diffuse and long disease. They have high rates of restenosis. And really here, the goal is to, in patients with CLI, with a wound, to perform straight line flow to the foot. We'll talk a little bit about an angiosome-based approach. For claudicants, really should be working on this if they have moderate to severe claudication with a greater than 50% diameter stenosis. Infrapopliteal vessels cause foot claudication, not calf claudication, or if they have multi-tibial disease with tibial vessels, really should you be thinking about doing revascularization. You can consider doing prior to considering infrapopliteal, before going on to treating below the knee, you really need to treat everything above the knee first. Most of the time that will take care of the patient's symptoms. Again, going back to the flow principle and Bernoulli's law, that flow is proportional to the radius squared, that obviously larger vessels provide better flow, which relieves symptoms better than working after these tiny vessels, which can range anywhere at the ankle down to 1.5 all the way up to at most 4 millimeters. And so better to work on the inflow than work on these smaller vessels below the knee. If you look at new task guidelines, which were published by Dr. Jaff and CCI in 2015, this is an update. Remember, the original task guidelines did not have anything regarding infrapopliteal disease. This more define what task A through task D lesions are, again favoring in this arena, or I think we're looking more at a balloon or endovascular therapy, as this is appropriate for these lesions. If you look at revascularization from the ACC, it's again, we don't really know, and that's the statement from the guidelines, is that revascularization of these patients with claudication is currently unknown. So for patients that have it, I think it's important to have this. If they have isolated foot claudication with infrapopliteal disease, really we don't know what the greatest approach or the best approach at this time to do with these patients is. What about infrapopliteal revascularization using drug-eluting stents? As I mentioned earlier, there's 5 trials looking at this. Clearly, versus balloon alone, DES was better than bare metal versus PTA, but no change with respect to claim outcomes. DES can be considered for short lesions or for flow-limiting dissections. Here's a list of the trials, the 5 trials looking at DES for below the knee. I think the important thing here is this drug-coated stents or bare metal stents are good to tack up dissections. PTA works very well as long as the PTA is able to keep the wound open long enough or keep the vessel open long enough for the wound to heal. If it occludes after the wound heals, then it doesn't matter because the level of metabolic demand required to heal a wound is much higher than it is to keep the skin intact. So it's not surprising that there is no difference with respect to limb outcomes using DES versus bare metal. However, you look at DES long-term outcomes, obviously we've shown in the coronary literature that DES is better than BMS for short lesions, and the same thing has occurred here below the knee. What about drug-coated balloons? There's just recently released a trial looking at Lutonix below the knee drug-coated balloons, but the one other study that was out there was the Impact Deep CLI trial. This involved 358 patients randomized 2-to-1. This was actually stopped early and the balloon withdrawn from the market due to a higher amputation rate with DCB, 8.8% versus the PTA alone. There's been this question of whether or not the balloon itself, as is known in DCB technology, 80% of the covering can come off and only 20% of the drug basically remains. If you're talking about distal embolization, using these balloons in these patients with below the knee, they really have limited runoff and they're not going to be able to tolerate this. So this has been ascertained as a potential cause of the patient having worse outcomes in this trial. The other big issue with this, and I think this has been addressed in an editorial by Dr. John Laird and Jack at the publication of this, also looked at how these balloons were coated. These balloons were coated and then not fully inflated and then shrunken down like it is in the SFA and popliteal, but these were basically coated already wrapped. Therefore, you're going to get a decrease in the amount of drug that's being given, and it's not going to be a homogeneous drug distribution, also influencing this trial. At the end of the day, this balloon was withdrawn from the market, and ongoing research is occurring. Again, the other trial that's not listed here is the most recently, within the last 1 to 2 months of the third quarter 2018, the Lutonix balloon showing a benefit of below the knee revascularization using drug-coated balloon versus PTA alone. So currently here in the infrapopliteal revascularization, the AUC criteria, basically you have a variety of options, including PTA for most below the knee lesions. You can use DES for complex lesions or dissections, but really you're looking at PTA alone. In green, with DES as needed if the patient has flow-limiting dissections or restenosis. If you look at patients for CLI, again, these are the sickest of the sick. CLI intervention was the first intervention done by Charlie Dotter back in the 1960s. A picture of the lady who presented with her critical limb ischemia. Charlie Dotter intervened upon the SFA and basically limited to a limited amputation. She then died 3 years later, not from her wound, but she died from congestive heart failure, underscoring that these patients have complex comorbidities that require careful attention to not just what's going on in their legs, but also what's going on in their heart. Those patients that have critical limb ischemia, they are the highest risk of adverse events. The risk factors for CLI are basically older age, ongoing smoking, and diabetes. Those are the big ones to look for, obviously, along with lipids, but diabetics and smokers are the worst, especially those over the age of 70. So it's very, very important to underscore and to review this in your patients that come to your clinic who fit this criteria, to give them the signs and symptoms of CLI so they know what to look for. On the right-hand side of the screen here, you actually see the original lesion that Charlie Doddard using his own technique in this same patient, and a successful outcome across the board. There's a class 1 recommendation in patients with CLI that revascularization should be performed basically to minimize tissue loss. Really, CLI should be treated in an interdisciplinary care team. This is not just about revascularization, but treating this wound, getting it amputated, treating for underlying infection. This requires a complex team of vascular specialists, infectious disease, orthotics if need be, prosthetics if amputation or partial amputation is required. And really, endovascular therapies are recommended as a class 1 recommendation to establish inline blood flow for these patients with non-healing wounds or gangrene, mainly because these patients, there's no data versus open in the Basel trial, even though the ongoing Basel 2 trial is ongoing, as well as the BEST trial out of Boston with Kenny Rosenfield, that these will further look at data looking at endovascular approach for CLI. However, at this time, given these patients are often very, very sick with multiple comorbidities, endotherapy appears to be somewhat more favorable and should be considered. And really, your goals of therapy with CLI, again, 4 being rest pain, Rutherford 5 and 6 being minor versus major tissue loss. Your goal is to relieve pain, heal the ulceration, prevent major amputation, improve the quality of life. Remember, these patients with critical limb ischemia have a quality of life equal to that of terminal cancer, and it's critical that we're trying to improve their quality of life, as well as prolong their survival, both in combination with the intervention, but mainly with good medical therapy. When you look at infrapopliteal revascularization, there's this concept of angiosome directed, and this is basically looking at the vascular territory supplied by a specific source artery. If the lesion is located on the top of the foot, we really want to go after the anterior tibial because that provides direct flow to that wound, and therefore should be able to look at this. This is based on some data from the plastic surgery literature and also identified from injection of dye and cadaver lower limbs without arterial insufficiency. There's some question whether or not this is beneficial or not. There's been one study looking at direct flow versus indirect flow. So if you could not get open the anterior tibial, but you could get open the perineal, and the perineal was able to supply collateral branches to the anterior tibial, which one is better for healing the wound? Direct flow is a little bit better than doing indirect. However, it's not clear exactly if this is the only approach that's valid. I think most of us will opt to open whatever we can to optimize blood flow to heal the wound. And with that, I'll stop. Thank you very much for the opportunity. Thank you for listening, and to SCAI for all their support in this endeavor and advancing the education and the awareness of peripheral arterial disease. Thanks so much.